Welcome to this module, which will teach you an approach to reading head CT scans. This presentation is designed to teach you a practical and systematic approach to reading head CT scans. Upon completion, you should be familiar with the normal anatomy of the brain and be able to identify classic abnormalities. Before we begin, there are some key concepts about CT scans you must understand. The first is windowing. The human eye can only appreciate about 16 shades of gray. The brightness of each pixel is measured in Hounsfield units, named after the inventor of CT. Because the CT scanner detects levels of gray beyond what we can all see at once, we have to set a range to what is shown to us. This is called windowing. Window width refers to the range of attenuation or Hounsfield units of all tissues of interest. Therefore, tissues in this range will be in shades of gray, and tissues outside the range are either black or white. Window level refers to the central or median Hounsfield unit of the window width. This diagram illustrates wide windowing on the left versus narrow windowing on the right. Here are examples of the three most common windows used in head CT. The brain window facilitates examination of the brain parenchyma and internal structures. The bone window is best to evaluate the skull and facial bones. The subdural window is sometimes used to better evaluate the subdural space for bleeds and other pathology. CT images can be oriented in different planes. The most commonly used is transaxial. Coronal planes are good for evaluation of the pituitary and sinuses. Sagittal planes are more often used in MRI. Now we can begin our approach to the head CT. As with most image interpretation, it's important to start with the easy stuff that is often forgotten. Make sure to note patient demographics and the date of the exam. Also make note of any previous imaging that can be used for comparison. Finally, it's important to take into account the technique of the study, for example, whether contrast has been used. Using a systematic approach, we will start from the inside and move outwards, taking special note of the structures listed here. In the midline, there are four major structures you should be familiar with. Click on the names to see their location. Note the pineal gland is often normally calcified, making it easy to find. When examining the midline, one should always evaluate for midline shift. Drawing a vertical line down the center should show relative symmetry between the two hemispheres. The septum between the lateral ventricles should not deviate more than 5 mm from the midline. Here are two examples of midline shift. On the left image, an abscess causes shift to the left, while on the right image, a tumor is causing shift towards the right. Moving on from the midline, we will examine the ventricles. Click on the names to see their location. Ventricles are CSF-filled structures easily found near the midline. When examining the ventricles, evaluate for changes in symmetry, size, shape, and density. Here are some common examples of ventricular pathology. Click on their names for visual examples of each. Next, examine the cisterns. Click on the names to see their locations. Again, make note of their size, symmetry, and density. Make note that cisterns often fill with blood in subarachnoid hemorrhage and can fill with pus in the setting of meningitis. After the cisterns, we will start to examine the brain parenchyma itself. First, we examine the four individual lobes. Click on their names to see their approximate location. Next, it is important to examine the deeper structures of the brain. Included in these are parts of the basal ganglia. Click on their names to see their location. Finally, lower down in the brain, examine the structures of the brainstem and cerebellum. Again, click on their names to see their location. While examining all the parenchymal structures, we should keep an eye out for common pathology. On this slide are examples of brain abscess and neoplasm. Note the ring-enhancing quality of the abscess. Also, note how the tumor enhances with contrast and is surrounded by a dark area of edema. One common indication for brain CT is for evaluation of possible infarction. Infarcts can be categorized into acute versus chronic. Acute infarcts are more difficult to spot, so we look for clues. On the left is an example of the hyperdense MCA sign, where the MCA becomes bright due to occlusion. On the right, we see a loss of the normal grade white border due to vasogenic edema. Chronic infarction is often easier to see. First, there is often a focal area of hypodensity. Secondly, due to atrophy, there is midline shift and retractment of the parenchyma away from the skull. When you see an infarct, it is very useful to try to determine the vascular area affected. Here's a diagram showing the different distributions of cerebral arteries. Next, we look for evidence of a bleed or hematoma. There are two types of hematomas associated with the brain periphery. Subdural hematomas are often more chronic and are the result of tearing of the bridging veins. Look for a crescentic-shaped hematoma that crosses suture lines. Epidural hematomas are usually more acute and are due to rupture of the middle meningeal artery, often after trauma. Look for a biconvex, lenticular-shaped hematoma that does not cross suture lines. Here are examples of each. Click to see the shape of the hematoma more clearly. Note the crescentic shape of the subdural versus the lenticular shape of the epidural hematoma. Next, we look for evidence of a subarachnoid hemorrhage. These are usually due to ruptured aneurysm, trauma, or AVM. Their presence is often seen as blood in the subarachnoid space and or ventricles. The first place blood is often seen is in the intrapedunculair cistern. Finally, look for evidence of intraparenchymal hemorrhage. These are usually caused by hypertension and appear as blood within the parenchyma itself, often surrounded by dark edema. If you see a bleed, you can assess if it's new or old by its density compared to the rest of the brain. Acute bleeds are hyperdense, usually 80 to 100 Hounsfield units, which is caused by a protein hemoglobin component. Note that they can be hard to spot if hemoglobin is low, less than 80. Subacute bleeds can be either hyperdense, isodense, or hypodense relative to the brain depending on timing. The loss in density starts from the periphery and goes to the center. Chronic bleeds are hypodense relative to brain. After looking at the parenchyma, we move on to examine the sulci. Click on the names to see their location. Sulci will become deeper and more prominent with age. Blood in the sulci are indications of subarachnoid blood, as shown here. Now we switch to the bone windows and have a look at the sinuses. Click their names to see the location of the major sinuses. Look for evidence of sinusitis by examining for any air fluid levels in the sinuses. Also, don't forget to evaluate for mucosal thickening, blood in the sinuses, especially with a history of trauma, and any polyps or mucus retention cysts. We now turn our attention to the bones of the head. Examine the skull, sutures, and mastoid hair cells. Click to see their location. Look for fractures and any obvious surgical changes such as craniotomies. Lastly, don't forget to examine the skin and soft tissues outside the skull. Subgaleal hematomas, foreign bodies, and surgical changes should be noted. Congratulations! You have finished the presentation. You have been shown a systematic approach to head CT, and now should be able to identify major anatomy as well as common abnormalities. We will now summarize. To recap, before you even look at the images, start with the basic information. Check for old studies and take note of the technique. Then look at each part of the brain systematically. We started from the middle and worked our way out. In each area, identify the anatomy and look for any pathology. Here's a list of things not to miss. It is important to be consistent, so try to use the same approach every time. Thank you for your attention. This is the end of this module.